I'll discuss the standard for muscle-invasive bladder cancer today. And as I was driving in and kind of thinking about this talk, I kind of heard my dad in the background over and over again when I was a kid. He would say, "Son, if you're not going to do something well, don't do it at all." And that's kind of something that occurred to me. So I thought I'd start out with a case: healthy 85-year-old, some well-managed comorbidities, on lisinopril and simvastatin. Back in the day when it was fashionable, he smoked quite a bit, otherwise quite healthy, quite fit, hunts and fishes. And on appearance and on his evaluation, there's nothing that kind of jumps out. He did get a CT scan, which in fact showed a fairly sizable tumor over the left ureteral orifice. And here's just some representative images. You can see again here on the left-hand side, a pretty decent-sized tumor, surprisingly no hydronephrosis. And, as we kind of think about this patient and all of our patients, we're really trying to identify who's a good candidate for trimodal therapy. What does that actually look like? How does this compare to cystectomy with or without neoadjuvant chemotherapy in terms of oncologic efficacy? Ultimately, I'm a cancer doctor, and one of my major goals is to keep people alive and not dead of cancer, and then look a bit into the adverse effect profile and quality of life. So, the data that's been generated really over the last 20, 30 years, I think appropriately has focused on highly select candidates. So these are going to be patients with small tumors. They don't have any evidence of extra bladder disease, no extensive CIS, as Dr. Stewart mentioned. We want to make sure that the lymph nodes are looking okay, nothing large problematic there, certainly no metastases. That's going to generally preclude you from cystectomy or any type of local regional treatment. We don't want to see hydronephrosis, which is typically a harbinger of more advanced disease. And absolutely, the bladder should function properly. And we want to be able to scrape out the entirety of the tumor, do a maximal debunking transurethral sectional bladder tumor, where going into this, you've actually got fairly reasonable control. And it's important as we kind of think about the data that exists that we recognize that these are the type of patients that have been prioritized. And preparing this talk, there's really a couple of groups that have really been thought leaders, pioneers, and have the largest experience. And I thought I'd just share some of that data. We'll compare it to some of the cystectomy data and allow the group to draw their own conclusions. So the first one I'd like to share is a German experience, fairly sizable, 428 patients. They either had high-risk non-muscle invasive bladder cancer like Dr. Salmasi talked about, or muscle-invasive disease. And they got some combination of radiation with or without chemotherapy. And when we look at their group, about a quarter of the patients actually did not have muscle-invasive bladder cancer, and the remaining three-quarters or so did. And importantly, about 100 of those patients had disease that was actually into the muscle wall and not beyond. And their typical protocol looks like you receive a transurethral sectional bladder tumor, you wait 4 to 8 weeks to allow the bladder to heal and for the patient to recover. Then they're getting some combination of radiation chemotherapy to the pelvis, and then we follow them afterwards fairly rigorously with cystoscopies, many times with repeat transurethral sections of bladder tumors, cytologies, and this goes on. And it's a commitment at both the patient level as well as the team level, because they're generally monitored every 3 months for this first couple of years. So when we look at this group of patients, just kind of broad strokes right out of the bat, about 2/3 of the patients are disease-free initially. About a third go on to relapse and they require further treatment. Many times that is cystectomy. And to be honest, I think these days with modern surgery, modern enhanced recovery after surgery pathways, having received radiation doesn't preclude you from having your bladder out. There could be some additional complexity to the case, but generally at a high volume center, I'd say this is still a quite manageable situation. And here's their Kaplan-Meier curves, where we look at the relapse rates, and we look at muscle-invasive relapse-free survival at 5 and 10 years, and it's about 50, 60, 70%. Any type of relapse-free survival at about 10 years is about 50%. So about half the patients are going to relapse in some form or fashion. And I want you to kind of keep this number in the back of your head. We look at cancer-specific survival, we look at overall survival, and granted, this is an older population with comorbidities. Many of them had smoked for a significant portion of their life, and we follow them out to about 10 years. You can see that it's about a third to about a quarter of patients that are alive at that 10-year mark. So 50% cancer-free, and about a quarter to a third of people that are alive, and this is a German experience. When we stratify this based on the extent of the disease, when you have invasive disease, the overall survival at 10 years approaches 29% and about 45% at 5 years. So over half of the patients are actually dead at that 5 and 10 year mark. So that's a German experience, and granted it was an older experience, advanced stage disease, and probably the institutions that's really been at the forefront of investigating properly in the context of clinical trials is Mass General Hospital in Boston. And over the last several decades, they've had a whole slew of trials trying to identify the perfect regimens, the perfect patients, and that can look like some combination of systemic chemotherapy to sterilize any micrometastatic disease, alterations in the dosages of radiation that are delivered to the bladder, as well as the radiosensitizing chemotherapeutics that are administered as well. So a couple of years ago, they kind of compiled all of this massive experience, and when we look at their group, they had about 50% of the patients had T2 disease, kind of confined to the muscle layers of the bladder. About a third of the patients had T3 disease extending beyond the muscle layers, and then about 1 in 12 patients had more advanced disease kind of beyond the bladder. And when you look at the complete response rate initially, it was 72%, and I would say that looks pretty good. Ultimately, just kind of similar to the German study, about 30% of the patients required a cystectomy, either early on or subsequently over the course of their follow-up. Now when we look at kind of the snapshot of all patients, and this is extensive follow-up, 5, 10, 15 years, you can see that these cancer-specific survivals, again, fall on that kind of 50 to 60% range, and recognizing this is an older population, sicker population, that at 15 years, only about 1 in 5 people are still alive. And we kind of look at this through different pre-specified subgroup analyses. If you had T2 disease, designated in orange here, as would be expected, you do a little bit better. If it was T3, T4 disease, you're more likely to die of bladder cancer, and you're more likely to die quicker in general. When you look at the patients that initially responded versus that don't respond, if you didn't respond, that was a fairly poor prognostic factor. Those are the folks here in blue, and you can see if you initially didn't have a response, the likelihood of being alive at 10 years is pretty poor at under 20%. So if we kind of look at this data one more time based on stage at 10, 15 years, if you have T2 disease, so this is confined to the bladder, you do pretty well. But as that disease stage continues to advance, there's really a fairly significant drop-off in our cancer outcomes. So how does this compare to cystectomy? And one of the things I noticed from Dr. Stewart's talks was a complete lack of data, maybe 1 or 2 slides that were presented.
10-minute talk.
So this is a study from USC, John Stein, probably considered the largest world experience with cystectomy. And it spanned, the 80s, the 90s, the early 2000s. And we just kind of look at a snapshot here, all comers, patients receiving cystectomy. You can see that at 15 years, about 70% of them had not recurred. Now, those are a little bit different from the numbers that what we see and observe from trimodal therapy. And at about 15 years now, about 30% of those patients are still alive. And at 10 years, importantly, about 50% of them are still alive. Now, when we look at stage-specific survival, and the first one I'll draw your attention to is this is organ-confined disease. Now we're seeing recurrence-free survival rates in the mid to upper 80s. We're seeing overall survivals in that 60 to 70% range. Even when you have more advanced disease, the likelihood of being cured is about 60%. And when we develop lymph node metastases, we kind of know that tumor has the biological capacity to spread. Nevertheless, about a third of those patients do fairly well. And that's information you're never going to know unless those lymph nodes were removed, which is a standard part of an operation when you do a cystectomy. So here's kind of the curves, and we look at organ-confined disease. Again, excellent long-term survival, about 90%. As the disease continues to advance beyond the bladder, we still see recurrence-free survivals in the mid-60%. And then with the node-positive disease, about 1 in 3 men or women would be alive after their bladder removal. And as Dr. Stewart mentioned, we add on chemotherapy as a part of this multidisciplinary approach, and those outcomes would be expected to be somewhat improved. And in general, yes, there is a kind of a impact of surgery. And I think it's important that we're candid with patients that this is a long game. It can take 6 to 8 months until you get to really where you were before all of this. But in general, patients do fine once they get through those initial 90 days. So when we compare outcomes, and it's tough to do, these are select patients, series spanning a fairly significant amount of time, the kind of bottom line things I draw your attention to for overall recurrence-free survival at 10 years is on the order of, at 5 and 10 years, is about 70-60%. Over here, it's kind of closer to 50-60%. And when we look at the German experience, which is a little bit older, we see a little bit of a drop-off. So, in conclusion, oncologic outcomes in highly selected muscle-invasive bladder cancer patients receiving chemotherapy are somewhat worse than cystectomy, and they're even more pronounced when we take in data using neoadjuvant chemotherapy. If we don't do this lymph node dissection and assess those nodes, they could actually be omitted from receiving adjuvant therapies, which have been shown to be effective in modern series. And nevertheless, in patients that are unwilling or unfit to receive a cystectomy, trimodal therapy may be a reasonable option. Thank you for your time.